And today I'm here, I have the honor to interview Dr. CATERINA FEDE from the University of Padova. So Caterina, thank you for accepting my invitation. And I want to tell something to our audience, something that we just said before, that Dr. CATERINA FEDE lives in Padova, and Padova and Brescia are like 2 hours by car, so we are so close. But we decided to do this, to make this interview in English to reach the highest number possible of people around the world, right, Caterina? So let's do this. And I want to start this asking you, what do you currently do at the University of Padova?
Thank you, Laura, for the kind invitation. I'm happy to share our knowledge about fascia with all of you. So I'm a researcher at the University of Padova, but my background was not related to the fascia world because I'm a biotechnologist and I started my PhD related to nanotechnology and the nanotoxicology. So a totally different topic, but more than 10 years ago, I met Professor Carla Stecco here at the University of Padova in the Institute of Human Anatomy. And we started a collaboration together to understand the fascia also from a microscopic point of view, because she is an orthopedic, she is a clinician, and she's also an anatomist, so she knows the fascia from a clinical point of view and also from the gross anatomy. But she was very curious to understand if what she see in the clinical practice can be demonstrated also by the research, the histology, the cell biology, the molecular biology. So we started this collaboration to understand better how is the fascia, which are the different components, and we started from the deep fascia, but in the last years we also studied the superficial one, the visceral one, and it's very interesting and intriguing because much time we spend to study fascia, and much we have to discover and to study because it's a very intriguing world with a lot of factors that work together, and step by step we are trying to understand better this fascinating world.
Exactly. Today fascia is the topic, right?
Yes.
And we are both happy about this because in the medical field and in every field, in my field, in the fitness field, now everyone is talking about fascia, and this is important for our health, right?
Absolutely, and there is a huge increase also of scientific publication in the fascia, but, and it is a very good starting point, there is a little bit of confusion still now, because what is really fascia, what can be termed fascia, and also a confusion about the terminology, the function, the different type of fascia that has to be considered together but different. So there is also a lot of work to do.
Yes, about the terminology. A few years ago, everyone called the fascia connective tissue. But
yes.
Now I know that something is changing. I think that this changed thanks to Dr. Carla Stecco, right?
Yes, and she's collaborating with a lot of other researchers from around the world. And I think that is at least 1-2 years they meet every week in a Zoom meeting to find a consensus. So it's difficult also between experts of the fascia world because there is a very debate if it is a system, an organ, a tissue. So we have to be precise. If we want to share the knowledge about fascia, we need to find a consensus, the same terminology, and to be sure also to compare the different research that we are speaking of the same structure.
Yes, exactly.
So it is in the family of connective tissue, but is not only considered a connective tissue. The last version of the definition of fascia is a fascial system.
Fascial system, exactly. Okay, last 2 things before we really start.
Yes.
I want to say again, we start this 2 minutes ago that we are Italian, and we are both proud to be Italian, because Italy, I mean you, especially the University of Padua, you are at the top of the researchers in the world in this moment about fascia. So we are both proud about it, right? And another thing that I want to say to our listener is that I attended the virtual version of the World Congress of Fascia, and that was the first time that I listened to your speech. And I found you, and that speech was about fasciacytes, and we are going to talk about fasciacytes right now. And I thought that you were super technical, but also super easy to understand. So my listeners are people super technical sometimes, but also client, patient. So feel free to be technical, but also to explain to everyone. We want that everyone understand what fasciacytes are. So let's do this. My first question for you is about fasciacytes. So can you give me a super quick definition of it, and later we will go in depth of this concept.
Okay. Fasciacytes are cells, fascia specific of the fascial tissue, that are responsible for the hyaluronan synthesis.
Hyaluronan synthesis, so the production of hyaluronic acid, right?
Yes, yes, exactly.
And you and the researchers from the group of Dr. Calasteco discovered these cells. So how it happened? I mean, were you searching for that cells? Were you searching for something else? How it happened?
Casually, because we were studying the deep fascia in that moment, especially the fascia lata, but we were at the beginning of the comprehension of the different components of the deep fascia, and we were studying by histology the tissue, and under the microscope we found that there were a lot of rounded cells. At the first beginning, I didn't pay so much attention to them, but in a lot of different samples, we again found these clusters of rounded cells different from the classical elongated fibroblasts that we can find in all the connective tissues and also in the fascia. They were in cluster with a very specific morphology. So we tried to understand much more better their characteristics. They were similar to the chondrocytes, that are cells of the cartilage tissue. So we used also a marker for chondrocytes, but there are chondrocytes inside fascia, but no, because they were totally negative for the typical marker of chondrocytes. So we also try to find in the literature something to understand what these cells are, and we were attracted by a work in which the authors study the synovia, the skin and other tissues, differentiating some fibroblast-like cells that are in the family of the fibroblast, but with different characteristics. And so we tried to understand for which marker they were positive, and we found that they express the classical typical marker of fibroblasts, so we confirmed that they are fibroblast-like cells, but they express one marker that the fibroblasts don't express. This marker is specific for the chondroid metaplasia. It's a difficult name, but is to explain that they are fibroblasts with a specific function different. We don't know if it is a reversible transformation or irreversible, but they seems to distinguish from the fibroblasts, from their origin, to acquire a specific function. And we noted that around these cells there were a lot of hyaluronan-rich matrix, a lot of water, glycosaminoglycan, but especially hyaluronan. And again, we found that these fasciacytes were between the dense and the loose layer, because we know that the deep fascia is made of different layers, dense and loose, and at the border between the dense and the loose, there were these fasciacytes. It means that the dense layer is made especially collagen type 1, collagen type 3. In the loose layer, there is much more water and the hyaluronan. And at the border between the dense and the loose, we can find the fasciacytes, which are able to synthesize that hyaluronan-rich matrix. So they are responsible for the hydration of our fascial tissue.
So until that moment, you didn't know that there was something that was, or did you know that there was something, that allowed the production of hyaluronan? Or until that moment, you didn't know that?
We only know that the deep fascia was made of different sublayers. The dense one, rich of collagen, fibroblast, it's very dense, and the loose one, rich in water, glycosaminoglycans, especially the hyaluronan, and also some adipocytes, some blood vessels. Also by histology, the dense and the loose layer appear totally different. So the dense is more compact and dense, like the name says, and the loose is more rich in water. But we didn't know till now that there were a specific cell responsible for the synthesis of that hyaluronan. So it means probably that these cells can be activated or they can change their function, so increasing or decreasing the production of that hyaluronan.
We go back about this, and when did you understood that these fasciacytes were so important for the sliding of the tissue? When?
Because we compare in all our study, we compare the histology with the cell culture, with the imaging. So what we see under the microscope is also demonstrated by the cadaveric dissection, by the ultrasound imaging in vivo. And so we understand that this loose layer, rich in water and glycosaminoglycan, is that one that permits the gliding of the different fascial layers. So it is very important for the health of our fascial tissue.
And this is my next question. So why fasciacytes are so important? So for movement, my field, exercise and movement in general, right? But why fasciacytes are so important in our health?
Okay, we demonstrated that more or less 30–40% of the cells of fascia are fasciacytes, and they are able, in a healthy fascia, they are able to synthesize the correct amount of hyaluronan, because we also analyzed how much hyaluronan there is in the fascia. At the first beginning, we expected that there were a lot of hyaluronan, but it's not true. It's less with respect to the skin or the synovia or the eye. But in a healthy typical fascia from adult is always the same, is around 35–40 microgram per gram of tissue, and it remains constant. Probably it is the right amount that permits the correct gliding. It's enough to permit a correct gliding. So in the retinacula, for example, in the joint, we have much more hyaluronan. There, the range of motion is much higher, and so the hyaluronan in the water are much more. In the epimysial fascia, that is another type of fascia with a close connection to the muscle, which cover the muscle, the hyaluronan is a very, very few amount, only 6 micrograms, because that type of fascia has not the same gliding properties of an aponeurotic one. So it, like the thoracolumbar, for example, the thoracolumbar fascia needs to gliding much more with respect to the epimysial fascia. So for us, it is very important the the presence of the fasciacytes to permit a correct amount of hyaluronan. We think that in a pathological fascia, this amount of fasciacytes or the activation of the fasciacytes can change, and so the hyaluronan amount can be different in pathological situation. The hyaluronan amount, but also the molecular weight of the hyaluronan that can become more sticky and don't permit a correct gliding. So for a good functionality of our fascia, it is important, obviously, the components of collagen and the relative amount of collagen, of elastic fibers. It is important also the innervation component, but for a correct gliding and for a correct movement, also the hyaluronan is a very key element of our fascial tissue.
We go back about pathological fascia. You said something. You said in adult body, is it different, the amount of fasciacytes in kids, for example?
Okay, because we collaborate with the hospital, we don't have so much samples from very young patients, obviously for ethical reasons, but we are trying to understand also in animal studies and with some collaboration what happens at the first beginning. The hyaluronan can change with aging. We have demonstrated both in humans and in animals.
Sorry if I interrupt you. It decreases.
Yeah. The hyaluronan decrease. Increase the collagen amount, increase the thickness of our also intramuscular connective tissue, but decrease the amount of both elastic fibers and hyaluronan. So it means that our fascia with aging becomes more stiff, more rigid. So we know that in very young patients and also in our animal experiment, the hyaluronan amount is much more, but only in the first years of our life. After the teenager aging, we start to decrease our hyaluronan.
Unfortunately.
Yes. But the movement can help.
I know.
Because with immobilization, our fascia becomes more rigid.
And that's my next question. So what are the factors that can influence or change the production of the extracellular matrix in a positive or in a negative way?
Okay. The fascia is a very resilient and vital structure. It has a lot of cells, and with the receptors of these cells, the fascia is able to understand what is happening outside, the different stimulation of their extracellular environment, and so they can adapt the fascial tissue to the different situation. The situation can be both physiological or pathological. So the fascia can answer to changes of temperature, of pH. So we imagine, we have no demonstration, but there are some clinical evidence in which also the change of the pH can influence the rigidity of our fascia. An acidic pH, also after a very strength exercise, very rigid training, the pH becomes more acidic, and the day after our training, our fascia are much more rigid. Also, the temperature can influence. With the manual treatment, we increase the local temperature of only 2-3 degrees, but they are enough to create a more soft fascia, probably also breaking the hyaluronan molecules and improving the hyaluronan turnover. These are physiological situations that can happen in our daily life, but there are also some pathological situations like osteoarthritis. For example, the patient with osteoarthritis have much more rigid hyaluronan, with much more rigid fascia, with much more collagen and less hyaluronan. but also the sex hormones can influence a lot our fascia. When the estrogens are low, like during the menopause, the menopausal transition, the cells start to produce much more collagen type 1 that is more rigid. So it can be related to our fascial stiffness during the menopausal transition, and so with also some pain in some cases. The aging, as I mentioned before, influence again the fascia. So the fascia with the aging becomes much more thicker, with much more collagen, less elastic, and with less water and less hyaluronan. So also the absence of movement again can influence our fascia. They become more sticky and more rigid and more stiff. So a lot of factors, also drugs and mechanical stimulation again can affect our fascial tissue.
Smokes affect the fascial system? Also?
We don't have demonstration, but we think so. Also diet, but we have to distinguish the superficial fascia from the deep one. We think that the lymphatic drainage, the inflammation are more related to the superficial fascia that has a lot of vessels, of lymphatic vessels, and also a lot of immunity cells like mast cells that can regulate the allergic phenomena, the inflammatory responses also to some factors like drugs or like smoke. The deep fascia is much more related with the proprioception, with the force transmission, and so it is less irrorated by blood vessels, so it is less influenced by inflammation or responses to drugs and external effects, but it is more related to the proprioception, to the work together with the muscle, and so the hyaluronan regulate the gliding, and the collagen regulate the density of the deep, the dense layer.
All these things that you are saying are super interesting, and you are talking and you are speaking, and I'm thinking to what we do with LDOA, and all the things that you said take me to LDOA. So proprioception, the quality of the tissue, and all these positive things. I mean, this is my last question for you. So what happens when the fascial gliding in the human body is compromised? We are in trouble, right?
Yes, but fortunately it can be also a reversible situation, because it's normal that with aging and with a lot of external situation, the fascia can becomes older and more rigid. But with the correct lifestyle and with movement and with manual treatment, we can restore a little bit a normal, healthy fascia. When the gliding is compromised, it means that not always there is less hyaluronan, but it can be also that the hyaluronan is more sticky. It means that it starts to create some cross-link with other proteins that becomes more rigid. So with the correct movement and the correct manual treatment, we can break the hyaluronan long molecules. We have to think about the hyaluronan like a sponge that is able to link the water and to link other proteins. If the sponge is very well hydrated, is more soft. But if that sponge becomes very rigid, our tissue is not so able to move.
Yes, of course. Okay. Do you want to add something to what we said before? I have 100 other questions.
I understand. I hope to do another interview in the next future if you want. Yes. I think that step by step we have to share this knowledge, because I think that can be applied from a multiple point of view, from movement, diet, health, lifestyle, and also manual treatment, and also medicine. So also for the research world, it is important to have a feedback from the people who works with fascia, because we want to understand if what we see in the lab is what you see during your practice.
Of course, of course. Okay. Okay, Caterina, thank you very much for your time.
Thank you to all of you.
And absolutely, I will interview. I have other idea right now.
Okay.
Okay, I hope that our listener enjoyed this interview, and I will post this immediately on my Instagram and also on my YouTube channel. So thank you very much, Caterina. Stay there.
Thank you. Bye.
Okay. Bye. 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 Bye.